Hi everyone, I'm sorry I haven't posted in a while. I know my 25 followers have been missing me. I haven't really had any ideas for a video recently, especially ones that have to do with like cleaning or like lifestyle or like bipolar. I think I think I did one on like career and jobs, so I don't know if I uploaded that though, but I do want to talk about treatments for bipolar disorder. I think also this works for most mental disorders. So there are like a lot of different levels of treatment. I think I'll just go from the most severe to like the least severe. I think that would be the most helpful. So I guess the most intensive would be like getting admitted to a hospital. So there are some like long-term help for like schizophrenia, bipolar, depression, anxiety attacks, OCD. I've never actually heard people or know anyone who's been in there long term, but I personally have been there 2 weeks in 2013. It was a really eye-opening experience. I actually admitted myself because I didn't want to go home, and the things I experienced there were a little extreme. I got placed in kind of like an eating disorder like unit. It was for like younger people, so it was not as intense. They mainly watched our eating. I was like housed with like anorexic girls, girls that had like eating problems and like self-image issues, and like I don't have that, but they placed me there because I was eating a lot. I had like a really large appetite, and that continued for like a year or two. I had that ever since like 8th grade, so like 28. And this wasn't as intense as the under 18 unit for like actual psychiatric care. I was in there for like a week or two, and the maximum they let me stay was 2 weeks, because after that you need to be released. It was a short-term one. They didn't really have much to go on, so they just gave me bipolar. I was not OCD or schizo. I guess the one lower than that would be usually after you get hospitalized, you go into like an intensive outpatient program, and then you transition into you get into a partial hospitalization program first, and then an intensive outpatient program. So with the intensive outpatient program, you're basically going every day from like 10 or like 9 to like 3. So it is quite a while, and they have a lunch break. They teach you a lot of stuff. It's kind of like CBT, group therapy, just like being able to get on your foot. They have occupational therapy, art therapy, a lot of different portions that you can do. Well, so this is typically 5 days a week, and then you'll transition slowly to like 4 and 3, maybe 2, and these are only like 3 hours. So a lot of partial hospitalization programs will require you have that for like 3 to 8 weeks, and then the intensive outpatient, which is much less, they'll have you for also 3 to like 8 weeks, and then the next thing they should be giving you, transitioning you to is like you're kind of doing it kind of alone, and with that you are, when you do that, you could do 2 to 3 times a week with therapy. You could do any group classes, although that's kind of hard to find. But DBSA, it's an organization. It's a volunteer organization. With those are group classes and just like informational and just like support. So you can do that. You can do therapy, and you need to see a psychiatrist every few weeks. So when you're in like the partial hospitalization program and the intensive outpatient, you need to see a psychiatrist, and they'll typically see you more often. So every week or every other week, based on what the program suggests. You'll have your own therapist, and then you'll be able to attend certain groups. Typically there's a substance abuse, sometimes there's a eating, women's, PTSD, grief, and there's just like a lot of different things. So definitely I think that is a good middle ground between getting hospitalized and doing therapy a few times a week in psychiatry. With psychiatry, you shouldn't expect anything longer than 15 minutes. Sometimes it's even like 10. Your initial appointment will be 40 minutes, plus or minus 10 minutes. They'll kind of take your history and decide everything about you then, and they might adjust later on. In my opinion, I like women and minorities. They typically, I think for me, since I have really bad menstrual cramps and women health issues with women psychiatrists, they take that more into account rather than male therapies or psychiatries. Same thing with therapists. I think I really do not relate to male therapists, and I prefer female therapists. I think in general female therapists are a little bit more understanding of like women's health issues, and because of that I think I tend toward female therapists and minority therapists, just because there are some cultural issues that are easier to explain. I think I had a Caucasian or white therapist, and they were kind of shocked like how my mom treated me, but with the Asian therapist they were like, oh yeah, that's like really common, you know, like it happens all the time, and like this is how you deal with it, and sometimes it's like hard to wrap your head around and like figure it out and stuff. So I guess the last line of treatment, the basic and like you don't need it as much, is psychiatry every month or every other month or every 3 months, because in intensive outpatient you're probably going to need medication adjustment every few like weeks or every week. They need to monitor like certain symptoms, make sure like you have the right medications. Even when you're doing therapy, in the beginning you want to see a psychiatrist every other week, and then eventually they'll kind of have you like less times a week, because like they just want the medication to be more stable, not as many changes, and you know, all of that stuff. So think that's really helpful, especially when you're like not even needing to change the medication. It really helps to not change your medications at all, you know, like if you change your medications too often, you don't actually know what's causing it. You don't actually know what the effects are, and it's just more effective if you change them less often, especially if you don't feel any negative symptoms. For example, for me, I have not changed my medication dosage in like probably 3 to 6 months. I adjusted my Seroquel really briefly for a month, and that did not turn out well. On birth control, I'm on Seroquel 50 milligrams. I'm on Lexapro 10 milligrams and Lamictal. So Lamictal is a mood stabilizer. I have 400 milligrams. Seroquel is a antipsychotic and a sedative medication, and then Lexapro is a SSRI and kind of like an antidepressant. It works together with Seroquel and Lamictal just to have kind of like a mood booster, because for me, I'm definitely more on like the side of like I'm on the side of like depressive. I've only had like a few manic episodes. I've had manic episodes, I would say, like once every 4 to 5 years. I had one in 2013, depressive episode in 2015, a manic episode in 2019, a depressive episode in almost like right away 2020, another depressive episode 2022, manic 2025. So I mean, I think it's getting like slightly better. My medications are a lot more stable, and that's like really helpful for me. And eventually I think I'm reaching the point where I have therapy every other week. I have other forms of treatment, like, you know, having a really good support system, taking care of my health, having psychiatry every month or two, kind of having like a primary care appointment, gynecologist appointment, and with that, I think I'm working toward getting less treatment, but I think this is like the lowest form of treatment possible. So I really hope this helped. I would have like really loved to have all of this information online, and for me, I put this information online for, you know, those like that, like 3% of people who are diagnosed, maybe the other people and family members who didn't know this and can support other people. Just like general knowledge, I think, is important in this case. Yeah.